welcome everyone to the first session of our PBC Society Awareness Month speaker series. As many of you know, September is PBC Awareness Month, and we're thrilled to be hosting 5 live broadcasts this month featuring many of the top topics. You can learn more about our upcoming sessions by going to the Canadian PBC Society website at www.pbc-society.ca. And because we're live tonight, September 20, you can use the Facebook comment sections to ask your questions. So I'd like to get started by introducing our speakers. First, we'll hear from Dr. Andrew Mason from the University of Alberta in Edmonton. He'll lead off talking about understanding PBC. And Dr. Cynthia Tsien will follow from the University of Ottawa, speaking on PBC treatments and mechanisms. And I just want to say, whether you're newly diagnosed or a PBC veteran, I'm sure you'll enjoy tonight's session. So without further ado, I'll turn it over to Dr. Mason.
Thank you very much, and welcome from Alberta, where it's nice and sunny. This is what it looks like from my backyard. As you can see, it's Edmonton's not all strip malls. And this is our Canadian PBC Society in the Alberta region. And I think looking at us, the first thing you're going to ask is, why are there so many women? And this is like one of the conundrums we have with PBC. And there's a load of questions we can't answer. I mean, why is there a female preponderance? Some people will say that androgens are protective, but we don't know. And with PBC being an autoimmune disease, we don't even know if autoimmunity causes the disease process. We don't know what triggers the autoimmunity. We don't know what triggers the disease process. And we found out more about genes linked to PBC, and we don't know what they do. So we're in a quandary. So primary biliary cholangitis became an autoimmune disease in 1966 when Deborah Doniak and Ivan Reut, immunologists working with Sheila Sherlack, noted that patients made antibodies that bound to mitochondria and subsequently to nuclei. Now, the mitochondrial ones are the green ones you can see on the right. Now, this test has become more and more sensitive. So if you don't have abnormal liver tests and you're followed up for 6 years, only 1 in 20 people who have a positive anti-mitochondrial antibody will actually develop PBC. So what this means is, whatever triggers the development of these anti-mitochondrial antibodies, it's more common than the disease itself. So to make a diagnosis, we need 2 of the 3 following features. First of all, you need to have either an AMA, abnormal liver tests, and we call them cholestatic, and cholestatic means damage to the bile ducts. That's a high bilirubin or alkaline phosphatase, or a liver biopsy appearance of PBC. And as you can see here, this is a small bile duct that's being eaten up by an inflammatory response, and it's like this small bile duct here. So we now know that the bile will leak out of out of liver cells and will not go into bile ducts, and this will cause fibrosis and cirrhosis. But only 50% of people, we think, actually goes to get cirrhosis. And this is why there was a worldwide movement from you, the patients, who wanted to change this name from primary biliary cirrhosis to primary biliary cholangitis. And hats off to you for doing that, because you know only 50% of you do have cirrhosis. This is another view from my backyard. This is Lake Edith. So this is PBC, and it's a very confusing picture. And the symptoms are more than just from the liver disease itself. This is the major one that most people complain of, which is like a chronic fatigue syndrome, and many of the features of fatigue and PBC resemble chronic fatigue syndrome. And some of the studies that have been done from the UK on the left have shown that patients' muscles behave like muscles from patients with chronic fatigue syndrome. When you exercise, you get a buildup of lactic acidosis and it takes a long time to clear. And that's what we see in chronic fatigue. And that's from David Jones's group. And then Mark Swain, my colleague in Calgary to the south of me, has done some studies looking at blood flow in the brain of patients with PBC. And he's noticed that there's diminished oxygen saturation and diminished probably cerebral blood flow. So these are reasons on and above liver disease why you may develop a degree of fatigue. And in the liver itself, my lab's been working on bile ducts. And funnily enough, we see the same thing. We see that the bile ducts themselves don't handle sugar properly. There's a buildup of lactic acidosis, and there's a change in mitochondrial signaling. So this seems to be a common feature in liver, muscle, and brain. And this is something that we will work on moving forward. That's the view from the house again. This is Lake Edith. So PBC is a rare disease. It only occurs in 1 in 3,000 in the population, or 1 in 500 middle-aged women. As we discussed, it mainly affects women. It's not seen in children, but when it occurs in young patients, it is a much more aggressive disease. So if you're under the age of 35, you have a higher risk of needing a liver transplant. And then we know up to 5% of patients having transplants in Canada is for PBC. But if you look head to head for hepatitis C and PBC, it's about the same proportion of patients going for transplantation. So having a diagnosis of PBC doesn't mean automatically you need a liver transplant. PBC appears to be becoming more prevalent on a worldwide basis. And across Canada, it seems to be more common in the maritime provinces, bar one place. And that, if you look over here in the BC coastal region, we see a really high prevalence of PBC. And this is especially high in coastal First Nations. And they have extremely high proportion of patients with PBC, and these patients are also at higher risk for lupus and for rheumatoid arthritis and multiple sclerosis as well. So genetically, they look like almost like it's an autosomal recessive disease, which means one gene causes the disease. Now, we know that these diseases, autoimmune diseases, are found in families, and we see 2 families here with autoimmune diseases. Now, the Kennedys had Addison's disease, celiac disease, type 1 diabetes, and the Bushes, they had thyrotoxicosis. And I think Barbara Bush had hypothyroidism, and even Millie the dog had lupus. So they had a lot of autoimmunity in that family. This is a cross-Canada study looking at the genes that are associated with primary biliary cholangitis that was headed up by Gideon Hirschfield in Toronto with Kathy Stominovich. And the way this study went is to look at many hundreds of patients and look to see which genes were altered in PBC. And what we see here is that those dots represent areas of the genome where shows an increased risk of developing PBC. And one of the things we noticed immediately is many of these genes are associated with immune responses. and more specifically, their immune responses of how the immune system signals with one of the cytokines called interleukin 12. Now, the problem is we don't know whether the IL-12 axis is overactive or deficient in PBC. We just know that there are many genes contribute to a predisposition for PBC. Now, it's difficult to understand why we should keep these genes in a population if they're bad for us. Well, the interesting thing is that genes that used to be helpful to us are now possibly bad for us. So one of these genes here was in 2000 years ago, was protective against leprosy. And the very same gene now can cause an increased risk of PBC and an increased risk of Crohn's disease. So we have maintained these genes in our population, and now they're predisposing us to PBC. So what I can tell you about the genetic predisposition is there's a lot of different genes linked with PBC, not just one gene as suggested by the First Nations studies, but we don't know how they function. Either way, you need genetic susceptibility to disease. Now, this is sort of how we understand our complex diseases. We say you've got a gene or genes that predispose you to disease. You've got some environmental effect that causes immune dysregulation. So this is a common model, if you will. And this is what we have for primary biliary cholangitis. We have a set of immune genes that we just talked about. We have autoimmunity, but we don't even know if autoimmunity causes the disease, because we just discussed you can have an anti-mitochondrial antibody, but no disease. And some people with PBC don't even have an anti-mitochondrial antibody. So autoimmunity may not be causing the disease. In fact, what we do know is that immune suppression is not that helpful in patients with PBC. Then we've got some environmental factors, viruses, bacteria, and xenobiotics, which are essentially chemicals in our environment. So these are the potential triggers for the disease. And as you can see, there's more suspects there than on the last page. Now, cigarette smoke doesn't cause PBC, but we know smoking cigarettes makes it worse. And in fact, we know alcohol makes it worse, but alcohol will make any liver disease worse. There's a possibility that female hormones make things worse. People that have children younger are more likely to develop PBC, and certainly people that take hormone replacement therapy have a higher risk. There's the effects of autoimmunity there. Some groups have been working on bacteria, such as this unpronounceable one, Aromatoxyvorans. We talked about some of the genes involved, and then my lab is working on this idea that a virus is associated with PBC. And again, these triggers will only cause disease in people that have genetic predisposition. So that's maybe why some people will get an anti-mitochondrial antibody, but they get no disease. Now, one of the things that's not talked about very much is that patients with PBC may actually have some diminished immunity. So this is a study that was done across America about 15 years ago with Eric Gershwin and a lot of others working in the US at the time. And it shows that patients with PBC have an increased risk of developing urinary tract infections, tonsillectomies, having their gallbladders removed, and colonic polyps, as well as have an increased risk of certain cancers unrelated to liver disease, because this is a hepatocellular carcinoma, which is higher in patients with any kind of liver disease. And when you see something like this, when you see increased presence of infections and cancers, you ask yourself whether you've got diminished immunity. Then there's this issue about transplantation. Recurrent disease occurs following transplantation in up to 50% of patients. The stronger the immune suppression, the more likely you are to get recurrent disease, which goes against the idea of an autoimmune disease. And patients on cyclosporin, which has broad antiviral effects, are actually protected against getting recurrent disease. And finally, in that first year following transplant, if you get high cholestatic liver tests, that signals that you may get disease, recurrent disease, further down the line. And this is more consistent with an infectious process than an autoimmune process, because following transplantation, that's the time when you have your highest immune suppression. So highest immune suppression would lead you to get a recurrent infection in your allograft. And this is some of our work where we've been using antiretroviral therapy. This is one of our patients who's developed recurrent primary biliary cholangitis with some autoimmune hepatitis, and we treated them with these antiretroviral drugs, and then they've got improvement of their liver tests and their biopsy, and their cholangitis, which you can see up here, has largely resolved. So I have a slightly different model for PBC than other people. I think it, to me, looks more like an infectious disease model. Immunosuppression doesn't help. Early recurrence following transplant, when immunosuppression is maximized, an earlier recurrence is all suggestive of an infectious disease. We sometimes see passage of disease to non-related family members. And then we also see this occurrence of increased prevalence of PBC when moving from a high prevalence area from a low prevalence area. So when people move from India, for example, to Birmingham in the UK, their prevalence goes up. And so this is the model that I use. I think there's genetic predisposition. Our immune system doesn't work so well. And then when we get an infection, we get more likely to develop PBC, rather than the other way around, where we have an overactive immune system and we've tried to block the immune system and it doesn't really work. So we're still doing a lot of research. We don't quite understand what's going on. In my lab, I look at the viral pathogenesis, some animal models. We're still doing clinical trials now, as well as genetic studies, transplant studies, and we're making diagnostics. So what I haven't included there is some of the work that we're doing now on this metabolic changes in PBC. And just to finish off, I want to show you another patient who's been on antiretroviral therapy, who was in one of our trials. And this patient started on antiretroviral therapy with Truvada, which is a drug that's used in HIV, and some of it's used in hepatitis B, and Kaletra, which blocks retroviruses as well. And here we see that their alkaline phosphatase and their ALT improve slowly after a couple of years, as did their bilirubin, and they normalize their tests. Now, these drugs are being repurposed. They weren't made for the virus that I'm working on, but nevertheless, they appear to have some effect, so we're doing another follow-up study now. And with that, I'd like to take you back to the mountains, which, as I told you, are close to us in Alberta, and stop now and be happy to answer any questions you may have.
Thank you so much. That was terrific, and I hope everyone can hear me. Andy, can you hear me?
Yes.
Okay, good. So you can put down your sharing screen so we can see your face for the questions. And there you go. And I'll kick it off since I don't see any questions right now coming through from Facebook, but I expect there will be some. I'm wondering, we often get people calling us for patient support who have had their blood work tested and they're positive AMA, but their ALP is not super high. What do you do with those kind of patients? What's your strategy for that?
Well, so the treatments that we have now, and we're just about to hear from Cynthia, they are mainly directed towards treating the liver disease. And, you know, we've gone into quite a lot of detail about this is more than just a liver disease. And the treatments that Cynthia's going to talk about mainly don't have much effect, unfortunately, on the itching and on the fatigue and the exhaustion and the brain fog. So people will tell me, they say, you know, I've got bad fatigue, what should I do? And I would give them the same advice as anyone else with PBC. That is, there aren't good treatments for fatigue, but certainly we think that exercise is a good thing to do. That increases your endorphins and it makes you feel better. And that's the other thing I often encourage people to do, is to get in with other patients with PBC and share your experiences. But as far as treatment's concerned, if someone's alkaline phosphatase is slightly elevated, I would certainly give them ursodiol, but because that's been shown to be life-prolonging, but I would tell them it wouldn't really affect their symptoms.
Okay, we have a question here from Mary. She says, I also have NASH F2 and some F3. Does that put me in a road to getting cirrhosis at a faster rate?
That is difficult to answer. You may think it's intuitive that having two things would make things worse. So the question then becomes, do I see more people who have metabolic syndrome that's associated with NASH going to transplant with PBC? And so do I see people who are overweight with diabetes and hyperlipidemia more often going to transplant? And the answer is no. The answer is we see more hyperlipidemia in patients with PBC, but that's probably because of the bile ducts are blocked and then the cholesterol is not excreted properly from the liver. So there is not a lot of data to say having a little bit of NASH with your PBC makes it much worse, because we're not really experiencing that. And also, having said that, you know, a lot of us do have NASH. Anyone that's carrying an extra couple of pounds has probably got a little bit of fat in their liver as well.
Okay, thank you. I'm going to say we don't have any more questions on the live feed. Some more might come about while Cynthia's talking. People might have other questions. So we'll come back to you if that's okay, and we'll go right into Cynthia's presentation on treatments and mechanisms.
Thank you.
Sorry, just give me 1 second. All right, I will share my screen. Thank you for training us, Gail. I can see why now you did that. And here is my presentation. And are you seeing that? Yes? Okay, perfect. So I'll be talking about treatments and mechanisms of PBC. Thanks, Andy, for that excellent presentation. It's a lot to follow you. And so I'll be mainly talking about the treatments for PBC itself. I think you guys are getting a talk on itching and pruritus later on, so I didn't focus a lot on that. So the main medications we're going to be talking about are ursodeoxycholic acid, obeticholic acid, which some of you may be on, fenofibrate, and then just as a little aside, we'll briefly discuss budesonide as well. So ursodeoxycholic acid is the first line therapy in PBC, which a lot of people will probably be on already. And it is an anti-inflammatory and what we call apoptotic medication, which apoptosis is basically cell death. So it helps with preventing sort of cell death and what we say is toxic to the hepatocytes. Bile salts are actually toxic, and so the liver gets rid of the bile salts through the bile, and basically bile is a mixture of these bile salts and also these sort of detergents, what we call like these phosphatidylcholine. These are detergents that kind of form these little balls that allow toxins to be excreted from the liver, and it goes into the bile ducts, and then you can excrete that through the gastrointestinal tract. So the bile salts are toxic, but you have this bile salt export pump that takes the bile salts out of the liver. And then you have these other pumps that export these, as I said, like these detergents. And then you get these micelles that form to so that you can safely get rid of those bile salts without damaging your liver. And so in PBC, you can get sort of an imbalance in this. So you have relatively more bile salts, less of these factors that help prevent the toxicity, and then you get the toxicity. And so you get sort of this aggressive bile with more bile salts and less of these other elements like bicarbonate that sort of dilute the bile. And so you get direct toxic effects on the bile ducts. And it's thought that also it may also aggravate sort of this autoimmune injury. So ursodeoxycholic acid is this what we call like a post-transcriptional secretagogue. So it stimulates basically these pumps so that you can get an increased secretion of a more what we call a hydrophobic bile acid, so one that's less toxic, it's thought, to the liver. And it protects those liver sites, liver cells, and the bile ducts. It also decreases inflammation. So these things called like IL-2, IL-4, TNF alpha, so these like inflammatory molecules, and it's what we call anti-apoptotic. So again, preventing cell death, it's hypothesized. Urso usually has very minimal side effects. They say that you can gain weight, but usually limited to the first 12 months. People do complain of hair loss, and very rarely there's also some gastrointestinal upset. But there's a lot of data with urso over a long time, and it's considered to be safe in pregnancy. As you can see, the first pilot study was in 1987. So we do, like I said, we have over 30 years of data. And the first randomized controlled trial in 1991 used ursodiol at a dose of 13 to 15 milligrams per kilo. And there's a reason for that, as I'll go into later. And patients were either on urso or what we call placebo. So basically like a sugar pill, like not an active drug. In this randomized controlled trial, it was shown that urso improved basically biochemistry. So biochemistry basically means, when we do blood work, all those tests of your liver enzymes, so the alkaline phosphatase, the GGT, so it improved these liver enzymes. And it also appeared to improve outcomes with improved Mayo risk scores, which predict death and severe complications, improve cholesterol. And there have been meta-analyses which also showed that if you took people and treated them with urso versus nothing over 5, 10, and 15 years, that there was much higher what we call transplant-free survival in patients who were treated versus non-treated. So over 5 years, if you were not treated, there was about a 70% chance of surviving, and also without transplant versus 90%. 60 versus about 80% at 10 years, and 30% versus 66% at 15 years. And the survival is also significantly higher in patients with more moderate to severe disease treated over long term. So we were talking a little bit about dosage. Is more better? There was a multi-center trial, which was double-blinded. So that basically means both the researchers and the patients didn't know who was on what drug. And it was a very large study that they randomized patients over a year, and they did different dosages depending on patient weight. So they did a low dose, which was about 5 to 7 milligrams per kilo, a medium dose, 13 to 15 milligrams per kilo, and then a high dose of 23 to 25 milligrams per kilo. And what they saw was that the medium and the high dose were equivalent, so there wasn't really any benefit in giving people a higher dose, although there was not really any difference in side effects. But both of these were better than having a low dose, in that the liver enzymes decreased significantly, as well as there was improvement in the Mayo risk score. So it appears that if you do have a medium dose, that 13 to 15 milligrams per kilo, that does appear to be effective, and you don't really need to, going on a higher dose won't give you any additional benefit. But it is a medication that we do dose by weight. So that's why, it's important to let your doctor know if you're having large changes in your weight. So how do we know if patients are responding or not? Response is defined as hopefully an improvement in your outcomes. So we could look at your blood work. That's called a biochemical response. We can also look at actual damage to your liver. So if we did a liver biopsy and we saw that there was some damage and scarring to the liver, that's what I think Gail was alluding to before when someone was talking about a fibrosis score. So that would be a histologic response if there was some improvement, basically when you look at the liver with a biopsy. And we try to use something that predicts your outcome. So it's very nice to see that your liver enzymes have come down, but really the important thing is that we want to make sure that that translates into, less deaths, less cirrhosis, less complications of cirrhosis, less transplants. So a lot of studies have looked into, what's the best way of judging, have you achieved a response, so that I can tell you, oh, you've responded well, and we're hopeful, that will result in you doing better over time. And so a lot of studies have been done looking at the biochemical response. So that is, looking at your blood tests, and a lot of studies have shown, that the numbers are slightly different, but basically, if you have a reduction in your alkaline phosphatase, if you have a normal bilirubin, these are very good signs that have been shown to be correlated with outcomes, hard outcomes like death and liver transplantation. So the numbers do vary a little bit in the studies, but overall, you want to see that there's an improvement in your alkaline phosphatase. Now, unfortunately, up to 40% of patients do not have a clear biochemical response, and 7 to 15% of patients will progress to cirrhosis despite having a biochemical response. So even though your numbers get better, there is a small proportion of patients who will still have progression. And so that's why other treatments have been investigated. And most recently in 2016, the FDA approved a second-line treatment for PBC. So, as you can see, URSO's been around since the 80s, and so it only took about 30 years to find, another medication for patients who weren't necessarily responding. So, obeticholic acid. So it says, as you can see on the slides, it's a synthetically modified bile acid, 6-ethyl ketodeoxycholic acid. But basically, it is a specific kind of bile acid that is what we call an agonist of this receptor. So basically, it attaches to this receptor that's highly regulated in the liver, and it regulates that bile acid homeostasis. So essentially, that picture that I showed where you get the increased secretion of bile acids. So it's thought that the obeticholic acid changes what the bile acids that are expressed into something that's a little bit gentler and less toxic on the liver. And at the same time, it's also thought to have an impact on the inflammation. So just like the URSO, it's thought to reduce inflammation and actually reduce fibrosis as well. This was that paper from 2016. It was a 1-year study. Again, it was double blinded, so this is really considered like the gold standard of scientific research when both the patients and the scientists don't know which medication each person is taking. And patients were basically divided into 3 groups. So there were, here you can see on the white, basically patients who were on, so they were all on URSO, but these patients were also on the placebo. So basically a sugar pill, no active medication. And this was the first initial double-blind phase. Then there was a second group of patients who were on the obeticholic acid at a dose of 5 to 10 milligrams. And then the third group at an URSO, and then the third group was on a higher dose, so the highest dose of 10 milligrams of obeticholic acid and URSO. And this basically showed that the primary endpoint, so basically the point of the study, what they were looking for, was achieved. Namely, they saw a reduction in the alkaline phosphatase. And the reduction was down to about 1.67 times normal. So if normal is 140, less than that times 1.67. Also a reduction of at least 15% from baseline. So they wanted it below a certain cutoff, also reduced a certain amount, and a normal bilirubin. And this was achieved in 47% of patients, so almost half of patients at 12 months. And then this is basically just showing that at the end of the study, they actually had what's called an open label phase. So basically they unblinded people, the doctors could see who was taking what, the patients who were on placebo got the active drug, and people who were on a lower dose were allowed to go on a higher dose. And you can see that there was a significant improvement in the ALP in these patients who were on placebo, and then they got the active drug. Now, it's important to know that obeticholic acid is associated with slightly more adverse events than, say, URSO. The itchiness was very significant, and this is in a patient population who already, a lot of people have a lot of itchiness. And it seems to be dose related. So people who are on a very high dose, 70% experience itchiness. And although, as you can see, even the placebo, a lot of people were still itchy. So, at baseline, people are itchy, and then it did seem to definitely get worse on the medication to the point where about 12% people had to discontinue. So may be an option for people who don't respond to URSO. It is unclear if there's a survival benefit, but if you look at other studies, it does seem to be that if you reduce ALP, that generally is associated with better outcomes. And it's also important to know that there is a warning on serious liver-related adverse events. And there were a few cases of people who went into liver failure. And most of these cases occurred in what we call advanced disease. So when you have cirrhosis, you have sort of early cirrhosis, and then you have advanced cirrhosis. Advanced cirrhosis is that what we call Child-Pugh B and C cirrhosis. And so it was thought that potentially that the dose was too high. So instead of giving someone 5 milligrams every day, they say that when you have early cirrhosis, you should probably be only giving them maybe 5 milligrams once a week, and maybe not at all in these people with advanced liver disease. And I think that's, it's important when you look at these studies to know, are you the same patients that was in that study, right? So a lot of the studies maybe include people with earlier disease who are not necessarily super sick, who have very advanced cirrhosis, needing a liver transplant. So you just have to be a little bit careful to say, oh, in these patients who are not necessarily like having cirrhosis, that it's going to have the same effect in me. And you'll see that as well in the next few slides on phenofibrates. So phenofibrates have also been around for a very long time for people who are not necessarily responding to URSO or obeticholic acid. And they're actually lipid lowering agents. They've been around since the 70s and have been used to lower your various lipid components of the lipid profile. It's been used by the Japanese in PBC, and now more and more people are using it in the West. Just to recall, so with PBC, you have that sort of imbalance between, the bad and the good components of your bile. And so phenofibrates are basically these agonists that try to upregulate this protein MDR3 to try to increase the better part of the bile. So essentially, it's to try to reduce that bile toxicity. So you basically increase the transport of that good part of the bile, and that overall reduces the toxicity of the bile salts, and it decreases the synthesis of the bad bile acids, it's thought. So also, so in 2018, we had the first placebo-controlled trial of bezafibrate in PBC. Prior to this, like I said, the drug has been around since the 70s, but they were very small studies, not very good quality in that, it's not the gold standard like this, which is, placebo-controlled, randomized. And it was in 100 patients who were non-responders. Similar to the Ocaliva study, patients were on URSO, but they were either on bezafibrate or a placebo. And what they showed was that patients on the bezafibrate are in the orange, and patients with the placebo are in the blue, and the patients with the complete response, you can see there's no blue, and it's basically all orange. And, up to over 30% of patients had this complete response. And if you look here at the alkaline phosphatase and the bilirubin, you can see the placebo versus the patients who are on medication. There was, a significant improvement on the bezafibrate. However, it's still considered an off-label medication, which is why, Andy can chime in, but most people will, could at least consider OCA first in patients who are not responding to URSO. There's been some concerns, especially in the other studies that were non-randomized, about hepatotoxicity. So even though some studies have shown a reduction in the ALP, it has been associated with worsening liver failure. And there's a concern that actually you can get histologic progression. So even though your numbers are coming down, the liver's actually getting sicker. Although, again, there's not a lot of data in more advanced liver disease. Some other concerns are this elevation in serum creatinine. So it can make the kidney function go off a little bit. And a lot of people complain about the sort of muscle aches. There has been muscle injury. The one good thing about fibrates is that they do help with the itchiness. So this might be an option for patients who can't do the Ocaliva because they're having too much itchiness. The fibrates, kind of kill two birds with one stone, helps with the itchiness and may show some improvement with the ALP. But again, it's an off-label use, and so you'll have to have that discussion with your doctor. And then I'm kind of running out of time. I just kind of wanted to talk about, there's been so many medications studied in PBC. One thing that people were kind of looking at was this prednisone, budesonide. There's maybe about 10% of patients with PBC who do have like an autoimmune overlap. So that's sort of the thought that maybe budesonide could help there. And it's a nice medication because it's mainly absorbed in the intestine, but it's mostly metabolized in the liver. So you get that, dose directly to the liver without a lot of systemic side effects. So I don't know if people have been on prednisone before. They talk about feeling hungry and they gain weight, and people really don't like the side effects. Unfortunately, studies have not been very promising. There was one pilot study that was stopped due to futility. So basically the medication didn't work. They basically, showed no improvements in the Mayo risk score. And actually people were getting complications from the steroids, even though, you wouldn't think they would, but they were having like osteoporosis. So in summary, so the first line therapy that everyone should be on is the URSO. It has very minimal side effects and it's really been shown to be effective. If you are not someone who responds to URSO, I mean, there's 40% of people who don't, so there is a substantial number. You can consider second line therapy, which would be either obeticholic acid, which is approved second line therapy, but definitely can cause a lot of itchiness, or off-label second line therapy, which is a bezafibrate. And that you can discuss with your doctor based on your specific patient profile, especially the extent of the liver disease, because there's not a lot of data in advanced liver disease. And then with that, I'll open it up to questions.
Okay, great. Thank you so much, Cynthia. If you can stop sharing your screen, we'll have you full screen so people can see you when answering. The first question I have here is from Bob, and he asks, he is AMA positive and he has fairly good blood work. His enzymes are good. So he's not on any meds. He has some fatty liver. Other than monitoring, is there anything else to be done?
I mean, Andy can chime in too, but I think, if your numbers are good, from the PBC perspective, we look at biochemistry. So, like your lab work is good, that's great. From a fatty liver perspective, we also look at scarring and damage. So if you're followed by a liver specialist, they can usually advocate for doing some form of testing every couple of years, just to make sure that everything remains good. So these are things like a fibroscan, which kind of measures how much scarring and damage there is to the liver. And there's also like the blood test that you can do to see if you're getting any changes that are indicating any progression of disease. But this is something that's very slow, so you might only have to do every 5 years. So I think, if your blood work looks good, I think that's great. Obviously, it's something to discuss with your doctor, but sometimes for certain patients that I am a bit worried about progression, I'll do some of these tests to look at if there's any damage to the liver, these non-invasive tests. But I use, blood work quite a bit, and that's definitely very reassuring if the blood work is good. And, as I said, with a lot of studies, that does correlate quite a bit with outcomes.
Oh, thank you. Carol would like to know, have you used fenofibrates? And if there's a drop in WBC and HDL, like low to 18, is that a reason to discontinue?
So a drop in white count?
Just reading what I use. I think so.
Well, Andy probably has more experience than I do with fibrates. I've used them in a few patients who had very bad itchiness. The main complication I came across was the kidney damage that was an issue. And I was very, very hypervigilant about looking for any hepatotoxicity. I haven't come across the white count thing, though. I don't know, Andy, if you have.
No, but we haven't, got that much long-term experience with it, unlike the Japanese, right?
Okay, another question. I'm not seeing, at end stage 4, is there any reason to have another biopsy?
I think that's a little bit difficult to answer over, because that's kind of a clinical judgment question, like there could be a lot of factors that may impact, a doctor's decision to biopsy. So I think unfortunately that for me, that's not really enough information to give a response to. I'm sorry.
Okay, and we get this question a lot too, and I never know what to say. Is 137 a high ALP? Because I always say no. I think you'd be happy to have that number if you had been at 800, but I'm wondering what you say.
Yeah, there's definitely a lot of lab variation, but I use the 140.
Different provinces have different numbers as well, right? I think British Columbia has a very low top number. And so it confuses me when I'm talking to people. They feel that their number's high. Andy, what's your British Columbia number?
In Alberta,
Oh, sorry, Alberta. Sorry.
That's okay. You saw those nice mountains now. So in Alberta, it's 130. The issue with alkaline phosphatase is it changes with age, and it changes as by sex as well, and it changes with bone disease. So it's we shouldn't really look at this as an absolute or stare at it intently, like whether it's 201 or 199, whether you reach certain criteria or not. Many other things to look at.
So I have a question. I was lucky to attend the virtual EASL meeting, the European Liver Conference, and it looked like a lot of the research is showing that heading into the future, it might be like combination therapies, like taking 3 different pills right from the beginning. Not so now we take urso. If you don't respond, you go to the next line, and probably if you don't respond to that, you try something experimental. But it sounded like there was a lot of enthusiasm for combining therapies right from the beginning of disease. What do you think?
I would say definitely. If you've got someone who's young in a high-risk group who has severe disease, and there is really very little reason not to start them on dual therapy. The only reason not to is just to make sure that one thing is tolerated, because if you give 2 drugs and then someone starts feeling sick or gets a rash, then you've got to then guess which one's doing it. So that's the only reason not to start dual therapy. But I think we probably will start heading that way, especially when we've got different drugs that do different things. Like urso has a very different mode of action than does bezafibrate or Sindelimpar or these other PPAR agonists and Ocaliva. So I think we're going to end up, like hypertension therapy when you know 2 pills are better than 1.
Okay, there's a few more questions, but I think we're going to have to wrap it up because we do like to finish right on time. A couple of the questions are with regards to symptom medications, which we will get into in our third session of, I think it's on, or the 4th, on September 30th. So we'll leave those for now. I really would just like to say thank you so much to tonight's speakers. It's been a wonderful, informative evening. A little bit technical for me, I must say, but that's good. Lots of people love the technical stuff. I'd also like to thank our 2 speakers for their dedication to their PBC patients, which a lot of you know these 2 doctors, but they are clinicians, researchers, and educators. They're not one thing, they're many things, and it's important for PBC patients to know their contribution to our lives, making improvements in many ways. So we hope to see everyone at our next session, which is in French on the 15th, for those of you who speak French, and on the 16th, which is a week from tonight, for our English speaking. And we'll delve more, I think, in that session into prevalence and incidence and risk factors for PBC. So we have lots of different topics coming up. And thank you so much to the speakers again. And with that, we'll say good night.
Good night. Thank you for having us.